Hello, I'm Rima Koka, Professor of Pathology at the University of Maryland School of Medicine. My presentation will help contextualize your role in the Nosology program and help you maximize your contribution to the DO. I'll be using one of my specialty topics, malt lymphoma, as an example, since I'm a hematopathologist and know a lot about lymphomas and leukemias. But to kind of give you a sense of the history of hematopoietic malignancies, in 2007, the classification of heme malignancies was mostly based on anatomic, clinical, and histopathologic criteria. Eventually, they were categorized by where the cancer is detected, and then ultimately in 2022, the World Health Organization's 5th edition classification used cellular lineage data, clinical attributes, as well as genetic features to refine the classifications. This chart helps visualize the classification of B-cell lymphomas. This side is for myeloid malignancies, and we're not really dealing with that right now. On the lymphoid side, B-cell malignancies are under the chronic or mature lymphoid malignancies, and malt lymphomas are within the marginal zone. Marginal zone is where B cells have already undergone activation and class switching, ultimately becoming plasma cells or memory cells. If transformation occurs in the marginal zone, you get marginal zone lymphoma. At the time that marginal zone lymphoma was described, it was thought to be a low-grade B-cell lymphoma arising in extranodal sites. At this time, treatment mostly involved surgery, radiation, and/or chemotherapy. Now, though, we have come to understand that marginal zone lymphoma can be categorized into 3 different subtypes. The first is what was originally described, that is extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue. This is often called malt lymphoma, and this subtype is found outside of the lymph nodes and is often associated with chronic inflammation. Nodal subtype is actually marginal zone lymphoma that is still in the lymph nodes, and splenic marginal zone lymphoma affects the spleen. We also know the different causes of chronic inflammation that might increase the risk of malt lymphomas. And this has allowed us to drill down on the different etiologies that contribute to this entity. These can include infections, autoimmune conditions, and immunodeficiency conditions. Notice that EBV infection shows up in 2 different categories, under infection as well as in the post-transplant immunodeficient area. Currently, there is a very simple classification for malt lymphoma in the DO. It's essentially classified under marginal zone lymphoma, which is under B-cell lymphoma. As we get better at identifying the different etiologies of most lymphomas, we want to improve the classifications. The process of adding a new subtype to the human disease ontology includes documentation with supporting evidence so that we can determine what placement would be best. You want to list other potential parent terms based on anatomy, infectious agents, or any other etiologies. At that point, the new disease subtype will be added to the ontology by the DO curation team. You want to be very explicit about which terms to use and where to put the new disease terms within the DO. The different questions you want to consider while doing your research is whether the new information impacts classification, whether you need to add new disease subtypes, how strong is the evidence behind them, what are the sources of evidence, and is there an actual published classification by consensus groups. Now, why do we need to go through all this? Essentially, what we want to do is achieve higher accuracy and enhance the way we generate differential diagnoses. It's also a great way to align criteria with new knowledge. Subtyping can be based on different parameters such as genomic, transcriptomic, or epigenetic data. How the disease progresses, which organs are involved, as well as the different biomarkers that we might use to identify the diseases. So the bottom line for what we would like for your teams to do is to use your clinical expertise to identify disease classification evolution, what new connections can be made based on the current data between diseases, genes, organisms, etc. The actual disease ontology part is handled by Dr. Scrimmel and her team, so you don't need to worry about any of that. Here is how the semester's workflow can be organized. You would have a primary meeting with your group, at which time you would decide on a topic. You assign yourself a team member number, and start filling out the form on your own using your different research sources. You should try to meet as a team along with your mentors each month to share updates, clarify points of confusion, and then have a final meeting where you come up with a consensus opinion based on all the independent research that was done over the semester. Your team lead will then evaluate your form along with the final consensus and get back to you regarding any feedback or with any questions. These are the different questions that we put into the form, and I know this is difficult to read, so it's actually outlined here. The first is to review the current DO classification, how is it recorded, and then as you're reviewing, the considerations include how can we identify the disease based on the literature. Please include references. What are the definition sources, links, and how do they show up in the different clinical vocabularies? Disease nomenclature, has that changed over time? Would you recommend that it changes over time based on the research that you have done? And then would you change the way that it's classified? Also, if you want to give us other similar related diseases that you might want to add to the DO, please make a note of those as well.